Good evening to all the aspirants present here. Some more aspirants will be joining us soon. The topic for today is endocrine disorder, class 2, and the speaker that we have here is Dr. Avishek Roy, who is an associate consultant ICU in Apollo Multispeciality Hospital, Kolkata. And I would like to ask the aspirants to kindly mute your mic. Any uh, any question or queries, please ask in the comment box. In the chat box, you may drop it there. In the Q&A session, we'll be answering those. Thank you. So you may start.
So good evening, everyone. I'll be starting the second part of this endocrinology part. So previous class was on sugar control and the diabetes and the diabetic emergencies, and this is on the rest of the important parts pertinent for our ICU care. So the common disorders, the first portion that I'm going to discuss is adrenal glands and steroid hormones and their usage and the important areas to focus. So common disorders that will come up ICU regarding adrenocortical function are these listed here. So we can have a Cohen syndrome, which is primary hyperaldosteronism, while the aldosterone level goes up and causes few derangements. We'll come to that later. It could be secondary hyperaldosteronism, which is seen in patients who have hypertension, underlying heart failure, or chronic liver disease, where there is a secondary cause which leads to an increase in the aldosterone level. You can have hypercortisolism, where you have Cushing syndrome, characterized by an array of clinical features, which I'll be discussing, and Addison's disease. That's a primary cortisol deficiency from either the pituitary or the gland itself, and the clinical features again are varied. So I'll come first to the discussion on the adrenal insufficiency itself. So adrenal gland secretes mostly three types of hormones. So the layer wise from outside to inside, it has got the cortex and the medulla. The cortex is divided in three parts. We can remember is that GFR. GFR stands for glomerular filtration rate. Similarly, we can remember GFR. So it's zona glomerulosa, zona fasciculata, and zona reticularis. Zona glomerulosa secretes mineralocorticoids. The main or important one of them is the aldosterone. Fasciculata secretes glucocorticoids. Just remember the G is not for G. So glomerulosa secretes mineralocorticoids, fasciculata secretes glucocorticoids, and reticularis secretes sex steroids, the androgens, the testosterones and the estrogens. And the medulla has got a separate function of its own, namely the endocrinal part and everything that is there. It secretes the epinephrine, the norepinephrine, and all. So it's situated, the adrenal gland is situated anatomically over and above the kidneys. The right and the left has a bit peculiar distribution, but it's suprarenal in their distribution. It has got a separate fascia on its own, and the blood supply is directly from the aorta and some from the the kidney branches. Uh, so the nephric branches gives it a blood supply. Now that's the gland related part. What is the supragland control that we have from the brain? So we have the hypothalamus, which secretes something known as a CRH. This is pertinent for our cortisol. So CRH is cortisol releasing hormone. So hypothalamus, situated around the third ventricle, secretes CRH, which activates the pituitary at the pituitary fossa, activates the pituitary gland. More importantly, the anterior stalk or the anterior part of the pituitary, and it secretes the ACTH. ACTH is adrenocorticotrophic hormone, which comes and has trophic effect on the adrenal gland, which helps to secrete all this hormone. And whereas this via the mechanism of negative feedback, these hormones inhibit the release of both CRS and ACTH, and that's how the tightly regulated these are. So this everything, the secretion of cortisol is dependent on the circadian rhythm as well as stress. It does not have a constant plateau or a constant level of secretion throughout the day. It fluctuates a lot, and that's why we have a specific timing for drawing blood samples when we suspect Addison's. So cortisol is a hormone which is a steroid hormone. It's 90% bound to cortisol binding globulin, some of which belong to pre-albumin and some of which are bound to albumin. T half is around 70 to 120 minutes, and the cortisol acts by the intracellular receptors. Normal level in healthy patients are 5 to 24 microgram per deciliters. So physiological effects, mostly it's metabolic effects. Then we have cardiovascular effects, and these are the major two. So metabolically, they increase blood sugar levels by stimulating gluconeogenesis. They reduce the glucose utilization in the tissues, thereby again increasing the sugar levels. They reduce protein synthesis and promote catabolism. That's why it promotes the muscle mass loss if given in excessive amounts. And it also causes lipolysis. So free fatty acids are also increased in the serum, causing a kind of a acidic milieu on its own. Cardiovascular system, it increases the heart rate, increases the blood pressure. It has got a permissive action. It does not have a direct action, but it kind of helps the adrenal glands medulla to take part, and the epinephrine and the norepinephrine take action and thereby increase the blood pressure and the heart rate. It also has a permissive action on the angiotensin, and thereby hydrocort or cortisol helps to retain fluids and sodium. So these are the main properties of it physiologically. Now, most importantly in ICU, or other important properties, anti-inflammatory property. So cortisol or any steroids per se reduces the phospholipase A2 mediated activation of the inflammatory pathways. So it downstream from the phospholipase A2, we have got the arrays of eicosanoids, and the different mediators of inflammation like the prostacyclins, which get secreted. It inhibits the inflammatory reaction. It also suppresses T and B cell reaction, reduces the eosinophil in the blood, and therefore T, B cell, and eosinophils, neutrophils, these are all main, especially the eosinophils, these are all main macrophage produce or helping cells or macrophage type of cells, and therefore the reduced macrophage activity is also seen. The primary causes of adrenal insufficiency could be a pituitary cause or could be a gland cause. When it's a pituitary cause, so the pituitary cause could be anything like a tumor, a trauma, infection, infarction, inflammation. So if you got a tumor infiltration into the pituitary, if you got a trauma of the pituitary, or you have an infarction that affects the pituitary, infiltration in the form of sarcoidosis or hemochromatosis, you can have this. Similarly, if you have a gland which is affected by autoimmune disorders like polyglandular syndrome or primary Addison's with an autoimmune feature which affects the gland, it can have you can have adrenal insufficiency. Congenital adrenal hyperplasia, it's not so important in adults, but you can have it in children, which is one of the common cause of adrenal insufficiency in them. This is one of the flowcharts of steroidogenesis. So steroids again essentially are prepared from cholesterol by the enzyme cholesterol desmolase, and then it has got, it bifurcates to two different pathways. One gives rise to three different pathways. One gives rise to cortisol, one gives rise to the aldosterone, which is the mineralocorticoid, and one to the sex steroids, depending upon the different enzymes. And the congenital adrenal hyperplasia is a situation where all of these different enzymes are deranged in different manners. It is not a topic of discussion for today, but this pathway is important in that case. So other than that, in adult patients coming with primary Addison's, we have to always rule out an infection of the adrenal gland. So the most common infection of the adrenal gland are tuberculosis, histoplasmosis, cryptococcosis, primary HIV infection, and cytomegalovirus infection. I'll again repeat: tuberculosis, histoplasmosis, cytomegalovirus, HIV infection, and occasionally you can have a metastasis. For example, you have some abdominal tumor previously or a pancreatic malignancy, which an adjacent spread to the adrenals coming with hypotension. And it can happen that metastasis has weakened the adrenal glands functioning. So some of the drugs which are again used for patients with Cushing syndrome, but itself can cause adrenal insufficiency. So the CYP3/4 mediated, the enzymes which mediates are metabolized by the CYP3/4 enzyme. The inducers of them increases the metabolism of steroids and thereby promoting an adrenal insufficiency states like rifampicin, carbamazepine, etc. Directly does not cause adrenal insufficiency. However, few drugs like mifepristone and then chronic steroid use itself, because chronic steroid use reduces the hypothalamus pituitary axis functionality and reduces the steroid hormone action. And megestrol also is a similar kind of drug which reduces the HP axis activation. And also the steroid synthesis can be inhibited by different mechanisms like the inhibition of the 17 alpha hydroxylase enzyme, all the cholesterol desmolase enzyme, among whom these are the main important drugs: the metirapone, ketoconazole, and etomidate. Ketoconazole is one of them which is very readily available. It has got its own toxicity and side effect. Other than that, oral ketoconazole is commonly used when you suspect hypercortisolism. So we are discussing now adrenal insufficiency. So the ketoconazole can lead to adrenal insufficiency if used in other scenarios. Now, very rarely it can be due to hemorrhage in the adrenal glands, as we have discussed. So the most common symptoms in an ICU patient, moreover, would be hypotension, along with that some dyselectrolytemia in the form of hyponatremia and hyperkalemia, and we can have normal anemia acidosis. So the symptoms like fatigue, which are common in ward patients or OPD patients, or loss of appetite, and in cases where there is a cause is not the pituitary, that means the cause is adrenal glands, we have hyperpigmentation, because the areas, the promoter gene sequences which it helps to release ACTH lies very close to the melanin secreting areas, and thereby whenever there is a reduction in the levels of steroids, the ACTH level goes up. Parallel with ACTH, the melanin level goes up. So skin hyperpigmentation and postural hypotension, which is seen in adrenal cause, it is not seen in secondary hypoadrenalism or cortisolism like a pituitary cause. But very important to remember, you should always suspect in an ICU patient if you get these features: low blood sugars, hypotension, anemia, unexplained fever. Probably I missed out on mentioning this. Unexplained fever, it is one of the cause of a pyrexia, non-infective cause of fever in ICU. Adrenal crisis per se can be precipitated by an infection, trauma, surgery, stress, anything. What labs you can send? You can simply send a random serum cortisol and ACTH just to have an idea about how the axis is functioning. So if you got cortisol which is low and ACTH which is high, it means the gland is at fault. So your gland, if it is at fault, this cortisol is low in all of them. But cortisol low, ACTH is high, means the pituitary is normal. So it is the gland which is the dysfunctional. Whereas if your cortisol and ACTH both are reduced, it is usually the pituitary. However, in an ICU patient, the level of ACTH can also vary significantly, and therefore, only based on a cortisol and ACTH, that to in an ICU patient can sometimes be tricky. So do not go only by the blanket statement that I have discussed, and many things, particularly in ICU patients, are not well defined, or the values are not well described. So just remember it for usual for clarity purpose, but this ACTH test does not always hold true. Other than that, whenever we suspect that okay, the adrenals are not functioning well, you do a basic screening ultrasound, and followed by you do an MR of the adrenal glands to look at the anatomy. You may have to go for a biopsy to prove a adrenal histoplasmosis or a tuberculosis. Now comes the screening test. These are mostly important for a non-ICU setup, but for diagnosing up entity, which I'll be discussing later, the CERC. In those cases, ACTH stimulation test is very important. Now there are two types of ACTH stimulation test. So what is ACTH stimulation test? Physiologically saying, when you give ACTH, your cortisol level should rise. Simple as that. Now, if your ACTH, despite giving ACTH, cortisol does not rise by a certain amount, that means there is a dysfunctional HPA axis. So the first thing is to remember there is something known as a low dose ACTH test, where you give a 1 mg dose, and before and after that you check the cortisol level, and if the rise is less than 9 microgram per TL, it is diagnostic of an adrenal insufficiency. There is also, for diagnostic purpose, we can use a high dose adrenal ACTH stimulation test. The difference between the two is that when you suspect an adrenal insufficiency, and you want to be sure about it, physiologically saying, you should be using a low dose, because if there is a suboptimal function, not that the adrenal glands are completely depleted, but probably if not functioning well, you want a low ACTH test so that you can find out all the cases suspected to have adrenal insufficiency. If you give a high dose ACTH, probably the ones which are functioning less will function more in that scenario and give you a false positive result. However, the clinical trials have failed to show a difference between the two in terms of low versus high ACTH. And since low ACTH is very difficult to give as a bolus, so practically saying a high dose ACTH is what is preferred. So If you have any doubts regarding this concept, you can ask me after the class. So high dose ACTH, which is 250 micrograms of that is 0.25 milligrams of cosintropin, which is given, and then afterwards you draw samples at 30 and 60 minutes, and you infer based on the difference. Management of insufficiency of hydrogen insufficiency is simply giving steroids. So you give steroids, you adequately resuscitate the patients with giving adequate fluids, and you need to be looking out for patients who are candidates for developing hydrogen insufficiency, especially the ones who are on chronic steroid use. The definition of chronic steroid use is different in different textbooks. Many areas they mention as 5 mg per day for more than 4 weeks, at least within last 3 months. Some say 10 mg per day for at least 2 weeks within the last 3 months. But the main motto that we have to remember is that you 5 to 10 mg per day for at least 2 weeks within last 3 months. That's the definition of patient who is dependent on steroids. And the take home point is that even if this patient is not currently on steroids but has received steroids in the recent past, if they're undergoing any procedure like surgery or some kind of other intervention, it is always advisable to give some stress dose steroids during that part, during the surgery, or the especially at the beginning. This is one important chart. So this is again mentioned in the later chart. So the relative comparison of all the steroids. Now this I want to everyone to look here and concentrate, because I don't know whether questions can be asked from this, but definitely it is a very handy tool you can use in regular day-to-day practice. So what we can remember is that relative potency wise, if you consider that your glucocorticoid potency is 1 and the baseline molecule that you remember is hydrocortisone, so your hydrocortisone or cortisol is having that's a basic parameter or the basic molecule which has a glucocorticoid potency of 1. So just remember this. 5 times of that is methylprednisolone. So 1 mg hydrocortisone equal to 5 mg of methylprednisolone equal to 4 mg of prednisolone. 4 mg of prednisolone. So methylprednisolone is more potent as compared to prednisolone. So what we use, methylpred, is much more potent as compared to betamethasone, which is 25. Relative glucocorticoid potency is 25, but the dose wise is less. Dose wise it's 0.75. If I'm not, let's just cross check once. Yeah, so the betamethasone equivalent dose 0.75 is hydrocortisone 20. So I'll break it down based on the glucocorticoid potency wise. So hydrocortisone glucocorticoid potency is 1, methylprednisolone glucocorticoid potency is 5, betamethasone glucocorticoid potency is higher, 25, dexamethasone again equal to that, fludrocortisone again lower, 10. Now come to the glucocorticoid is to mineralocorticoid potency. Hydrocort, it is 1:1. For prednisolone, methylprednisolone, which has a higher glucocorticoid action, 4 or 4 to 5 is to 0.25. So it's almost 20 times higher glucocorticoid action potential action. Betamethasone, dexamethasone does not have any mineralocorticoid action. Fludrocortisone has predominantly mineralocorticoid action. Aldosterone, pure mineralocorticoid. So this is based upon the glucocorticoid and the mineralocorticoid potency. Coming to the dose wise or the dose wise potency wise, hydrocort 20 is equivalent to methylprednisolone 4 is equivalent to prednisolone 5 and equal to dexamethasone and betamethasone of 0.75. So this you have to remember, that if you are giving a 100 mg hydrocortisone to a patient and if you are asked to convert it to methylprednisolone or vice versa, so 100 mg hydrocort would be equal to 4 into 5, that's 20 milligrams of methylprednisolone per dose. Okay. Similarly, if you are giving 40 mg methylprednisolone, that is equivalent to giving 200 mg of hydrocortisone per day. So this is dose-wise potency, anti-inflammatory potency, as I've discussed, based on the mineralocorticoid and glucocorticoid action. Now, one thing is to just another concept that I'm putting forward is that when you want to curtail or reduce the inflammation in your body or use the steroid as an anti-inflammatory markers or anti-inflammatory agent, for example, acute respiratory distress syndrome or fulminant flare of any autoimmune disease, you want to use something which has an anti-glucocortic or rather glucocorticoid action or anti-inflammatory action. So use methylprednisolone or prednisolone over hydrocort. However, if you want to use something which is short acting and it has got blood pressure wise or it has got hemodynamic effects, for example septic shock patients, then we always prefer hydrocortisone, because methylpred and dexamethasone, they don't have the mineralocorticoid action. They won't help you with stabilizing blood pressure. So there you prefer something which has a higher mineralocorticoid action. So this is one important thing to consider. So when you are giving it for only ARDS purpose, use Dex or methylpred. When you are using for septic shock, give a hydrocortisone. Now, coming to again back to the study protocol that we use for ACTH stimulation. So there is a short 8 hour and 2 days infusion. These are again based on OPD data and all. What we standard follow standard guidelines say use a 250 micrograms of dose of ACTH. This is again based on your ward data and the OPD patients, how you suspect and then how you work up. For us, it's mostly to remember that what is the high ACTH stimulation test, and high ACTH and low adrenal glands indicate that the gland is at fault. So you act accordingly. If low ACTH, low adrenal, low cortisol, it's a pituitary which is mostly at fault, and you investigate accordingly. And then based on the underlying etiologies, you go and work up. Till that point, you supplement with steroids and you manage the electrolytes and the acid base balance. That's the entire point about managing these patients. And what I told previously about the chronic steroid abuse, steroid use patients, that how to manage them, just remember one rule, that when it is a minor surgery, for example, a patient who is dependent on steroids, the definition I've already discussed, you want to give them a hydrocort, give a 25 to 50 mg stat dose if they're undergoing a minor procedure like small incision surgery, some skin surgery, superficial surgeries, cataract surgeries, etc. But if they're undergoing major to intermediate surgery, give a low dose prophylactic cover, just like 25 to 50 mg BD to TDS, that's around 75 to 100 mg per day of hydrocortisone over 40 to 72 hours. So you start during the preoperative period, throughout the OT you have to give, and afterwards, generally post-operative day or two, 1 or 2, you can taper it off. Now this is outside of critical care purview, but you have to remember because many patients are shifted who have taken steroids for a longer time. They have come to your ICU. If you switch off the steroid just like that, they will end up in high Addison's crisis and they will have coma. Now, this is the most important entity that you want to be knowing about, that is CIRSE. CIRSE stands for critical illness related corticosteroid insufficiency. So what happens is critical in patients is there is a dysfunctional or insufficient functioning of the hypothalamo-pituitary axis. The major reason being your stress or the infection. So stress or infection, it tries to promote a cytokine inflammatory response, which in turn blocks the HP axis. It also reduces the hypothalamic activation and thereby the CRH stimulation of the pituitary, and it itself has an intracellular effect by which it reduces the steroid binding to different and inflammatory molecules and thereby promoting inflammation and reducing the steroid effects. Moreover, what it does, it blunts the steroid response. Supposedly, there has to be X number amount of response to a steroid dose or body's response to a steroid. In infection and inflammation, it mounts to X by 2 amount, whereas it should be mounting to X amount. So there is a reduction in the amount of response. It also causes a peripheral glucocorticoid resistance. So these are all the different mechanisms or thought of mechanisms. So increased cortisol or decreased levels of cortisol binding globulin, which is the major molecule where it binds, and also the glucocorticoid resistance, which are causes of this phenomena. So when you suspect it, you can send labs just like we have discussed about Addison's. We send the serum cortisol levels, we send the ACTH levels, but first and foremost, the normal cortisol, which is normally 5 to 24 microgram per deciliters, does not hold true here because your you don't know the exact level of steroids that or hydrocort that should be cortisol should be present in your blood when you are undergoing a stress. So normally it is higher. So instead, supposedly in an ICU patient, it should be around in the range of 50 to 60, which is higher than normal. But still, if the needed response is less than what it should be, it can be called as CIRSE. So it's a relative phenomenon. It's not an absolute. It's a relative lack of the adrenal glands to mount a steroid producing response with respect to stress. How to diagnose? This is the most important concept. The best diagnosis point is that if you have a cortisol level rise after an ACTH stimulation test less than 9 microgram per deciliters with a baseline of less than 20. If you remove this portion with a baseline, can it be diagnosed as CIRSE? Answer is yes. If your baseline is still above 20, but you suspect that the patient is having CIRSE and you're mounting the ACTH stimulation test shows a delta change, that is before and after ACTH change of less than 9, that can be also marked as CIRSE. A single value of less than 5 also mostly point towards that possibility of SARSI. Now, again, these are not, say, dogmatic or definite criteria or definition of the SARSI. I have found out the internet that there is no, as per the guidelines also, it tells about the pathophysiology but does not tell about the exact definition. So it is a dynamic phenomenon. And again, as I said, there are a lot of confounding factors which there is are at play while diagnosing. So there is one. This is a nice paper which was prepared, which was put forward by Dr. Anand. That this person is a godfather of all the trials regarding steroids used in ICU, be it steroid ARDS, be it pneumonia, and be it septic shock. So, what classification system was put forward is based on three things, that we can have uh, four possibilities. One is that you can have a baseline cortisol which is less than 34 or more than 34, and a delta change which is more than 9 versus less than 9. So we can have four possibilities. We can have a normal baseline cortisol with one group having normal response. So that is a normal group. So you say this. So if your plasma cortisol level is more than 34 and the delta 9, that is the change of cortisol level, is more than 9, so you have your response is adequate. This is one group. You can have less than 34 but still you can have a more than 9 or adequate response with respect to ACTH stimulation test, whereas you can have a less than 34 with response which is more than 9, and less than 34 and less than 9 response. So four groups. Now the interesting part is that we can think that, okay, the group of patients who has a normal baseline value, who have a normal mounting response or normal ACTH stimulation test, should do better. The answer is no. See here, the plasma cortisol level which is less than 34, having mount a more than 9 response, has a more probability of survival as the time goes by. Whereas those with a baseline level which is normal, however, the delta change is less than 9, is having the highest mortality. So despite the normal baseline cortisol, they have the higher mortality or lesser chance of survival. How would you explain this? So probably these patients are at a higher levels of stress from the baseline. However, they cannot mount the response that is actually required, and therefore putting their life at more stake. Whereas these patients originally have a less than normal, I mean less stress response, less amount of inflammation, but they have the capacity to mount the response as adequate like that should be. So they have a lesser mortality. In between, the other two possibilities have an in between mortality. So remember this: baseline values, if your baseline is higher but your delta ACTH stimulation is lower, that indicates a worse prognosis that you can have. What are the signs that SARSI can present within an ICU patient? It is almost similar to an Addison. So you can have fever. So fever can be there. You can have, delirium, altered sensorium, confusion, coma. Cardiovascular system wise is the most important sign, that despite fluid acceleration, if your blood pressure is not stabilizing, you have to think about a insufficiency of steroids. You can have lab parameters like hypoglycemia, hyponatremia, and hyperkalemia, but let me tell you that all of them need not be present. Do not expect that SARSI means hypoglycemia, hyponatremia, and hyperkalemia always. They might be having a normal calcium, but hyponatremia, normal potassium with a lower normal sodium levels. They can only have hypoglycemia and hypotension, but not have the dyselectrolytemias. They can only have metabolic acidosis, which is a normal anaerobic acidosis. And you can find and use hypereosinophilia, but again, there are many drugs, and if you give a steroid, again, the eosinophil count goes down. So not a sole feature per se, but yes, you can find it. So, coming to the different, mechanisms that you have already put forward, why a cortisol insufficiency would occur in a patient in ICU. So, it could be because of primarily the decreased synthesis or decreased cortisol metabolism or transport mechanism because of different, alteration of the protein bindings, different pro-inflammatory mediators, the cytokines and all, and different epigenetics, which basically, reduce, kind of reverses and it molds the overall milieu, overall metabolism pathways. So this is there. You can go through this once I provide you with this entire presentation. You can go through the different causes itself. Now, coming to another important part is when to use steroid in sepsis, and this is a bit conceptual. And although there are no clear-cut statements that can be made, but few things has to be noted. So steroid use in sepsis started as early as 1976, where they have used steroids in different animals, and they have shown that using steroids in animals has led to better outcome. However, previous studies with use of high dose steroids like 30 mg per kg per day of methylpred, which amounts to almost 1 gram, led to somewhat worse outcomes. It led to more flooded infections. So then came the important trials which are discussed with respect to steroids. One is Corticus trial, which showed that use of steroids probably was associated with earlier resolution of shock and somewhat lesser mortality. There was a Hypres trial which failed to show any benefit. Then later on came major landmark trials, which is Adrenal, one is Approx. In Adrenal, they use a steroid in form of infusion, and they showed that there was no mortality benefit and there was probably some chances of harm also as well. And but the Approx trial, which was more point more methodologically more sound, which is the recent most evidence based on steroids used in ICU, it showed that if you use steroids judicially and a proper dose in early steroids, there is associated with mortality benefit and early dissolution of shock. Where do you stand now? So as I said, that the initial few studies, they showed promising results with high dose steroids, but then again there was associated increased infections. The trial was refuted. Then NN came with another trial which showed that use of steroids in early 2000 associated with improved hemodynamics without an extra need of infection, and thus came the concept of stress dose steroids. So when you loosely use the term, okay, septic dose steroids, stress dose steroid, it means that it's a hydrocortisone of 200 mg bolus followed by 200 mg per day of hydrocort. That is usually the septic dose steroids. That holds true for an adult patient weighing 60 kg, where the dose is 3 mg per kg. And an adult, again, early administration of steroids was useful in reducing, as I said, the vasopressors. Corticus, no difference in mortality in any of the four patient groups. Then comes this is the Corticus trial. So there was no difference in 28-day mortality with hydrocortisone versus placebo. But Approx trial, which is the current most recent recommendation, it was done in ICU patients where hydrocortisone and fludrocort were combined. Hydrocort 200 mg per day plus fludrocort 100 microgram per day in patients with septic shock, and they showed that there was early resolution of shock. Ventilator free days was less. Ventilator free days was more, and there was overall improvement in the organ failure scores as well. As I said, Hypres trial failed to show any difference in the septic shock and the treatment, and Adrenal trial showed that there was no treatment benefit, rather there was some harm. Although after some retrospective analysis, all of this trial, Approx, Adrenal, and Cortisol, did show one thing, that if you use steroids, you may not be helping the organ function recover, but it definitely reduces the vasopressor requirement and the time to dissolution of shock. One might ask, how is it relevant? How is it relevant that if the patient doesn't improve, how does it relevant? In critical ill patient, you will never find one single intervention directly related to mortality benefit. Very, very few are there. So if you find something which is helping you to reduce your vasopressor dose earlier, helping in earlier shock management, definitely go for that. So do not always think very in a dogmatic way that you need to have a mortality benefit, you need to have a ventilator free days to decide upon a trial. So steroids definitely reduces your vasopressor requirement, and again, prolonged vasopressor can cause arrhythmias, it can cause toxicity, vein damage. So better to use steroids in these scenarios. Now coming to, so based on what I said is, what is the dose of steroid? When should you start? So what should be started? Steroids. Sorry, hydrocortisone, not cortisol. Why? Because it has got equal mineralocorticoid and glucocorticoid action. Now, when should be started? Before 2021 sepsis guideline came up, we had the 2016 guideline, which showed that it should be started. It was mentioned that it should be started only if, despite adequate fluid administration, vasopressor requirement is lost, not lessened. And what is the level? It's NORAD of 0.25 mics per kg per minute, which is equivalent to almost 15 microgram per hour of noradrenaline use for at least 6 hours. So you keep the patient, receive the patient, give fluids, start antibiotics, assess, start NORAD. When the NORAD level is going up beyond 15, you can start it. Now my question is, or if someone can ask you, okay, what if ADRS was used at the beginning? What if vasopressin can be used? So there is a simple, conversion that can be used. Is that you can there is a score which I have not mentioned. You can write it if you are interested, known as vasopressor infusion score. VIS. So that score can be used. You can convert the NORAD, ADR, or the vasopressin dose to each others, and you can have a score on itself. You can decide on starting the steroid in that cases. So later on, adrenal trend showed that okay, there is no benefit of using a steroid, as I already discussed. But again, approxstrat showed that hydrocod with fludrocod has a benefit, but not hydrocod alone in the previous trials. So now there is a lot of confusion. What to do then? So why we are clear that we have to use steroids when there is a fluid unresponsive kind of shock on noradrenaline, probably more than 0.25. Now, what should we add fludrocod with that? The trial says yes, we should start add fludrocod because the approx trial and the Corticus trial both used a hydrocod fludrocod combination. Sorry, no, the Anand trial used a hydrocod fludrocod combination where the benefit was shown. This is as per the trials. But if you look at the previous, this chart that I put forward, hydrocod and fludrocod has almost, equal. The fludrocod has higher, but the equal efficacy. Hydrocod has 1:1 of mineralocorticoid and glucocorticoid action. So physiologically saying there is not much of a benefit of adding a fludrocod. It is all the matter to how the patients were recruited in the trials that led to the different outcomes. So hydrocod plus fludrocod, you can add it. If you choose not to add, that is also fine. Now comes another important question. You might be facing it a lot if you are practicing critical care, whether to use bolus versus infusion. Hydrocod has a onset of around 1 to 2 hours, duration of action, clinical duration 4 to 6, and terminal half-life is around 8 to 10 hours. So hydrocod is not a short-acting drug per se. And boluses at 6 hour interval should be fine. So you need not need an infusion. So if you want to compare a bolus versus infusion, do not give only infusion. Do not start at 200 mg infusion because then its effect will come after a day. So if you want to use an infusion, give a bolus 200 stat followed by an infusion over 24 hours, or you use a 200 mg bolus stat followed by 50 mg QID boluses. Both are fine. However, uh, just for simplicity purpose, you can use a only bolus. That will reduce the nursing staff load and as well. You don't need an infusion pump for that. So bolus is, as long as you're not only using an infusion, you can use bolus or bolus followed by infusion. Both are fine. Now the recent sepsis has said that you can use it whenever you think that there is that ongoing vasopressor need. I mean, patients during the resuscitation phase, if you are having an ongoing vasopressor need, you should start steroids. They have omitted the amount of steroids or the amount of noradrenaline that should be defined. So it makes our life easier. So you should start cortisol or hydrocortisone 200 mg per day dose on a bolus followed by infusion. Either way is fine. Not to be used or not only the infusion that should be used. And more importantly, you can add fludrocortisone if you want. The choice of when to start is kind of, it based on the patient to patient, it varies. But whenever your NORAD requirement is going up rapidly and you are using a second vasopressor, supposedly NORAD was going up beyond 10 and you are added vasopressin on a radial, start steroid then and there itself. Now the recommendation as per the 2017 guidelines in ESICM. So what, just a quick brush through. So do you use an ACTH stimulation versus a random cortisol? In ICU, you can use any of them. It is not the random cortisol is not, useful. Plasma free cortisol versus total cortisol. They say total cortisol to be used. Physiologically, free cortisol is better. However, it is very cumbersome. The labs don't measure it. So you use a total cortisol. We don't use a salivary cortisol to diagnose it because these are all ICU patients, so it's difficult to sampling the salivary glands. You don't think of it, right? So you straightforward give steroids. So only serum cortisol. Whether to use high versus low dose ACTH, physiologically saying yes, low dose should be better. But again, as the trial showed no difference, so high dose ACTH should be done. And what should be done, based upon which should we give steroids, look at the response versus a 250 microgram dose. If you want to really assess the response, you can do with a 250 microgram test. But very rarely it is actually done in ICU because you've got loads of other problems to deal with. If you suspect, you send a lab value of steroids. And if your patient is going into sepsis, flooded sepsis, start off there itself. If you suspect, patient without sepsis but in shock, you suspect steroid insufficiency, send a cortisol when the labs come back. If it is low, you start off there itself. Recommendation for cortisol in critical ill patients: severe septic shock, not responsive to fluids, as I said, ARDS within 14 days, not later than 14 days. Community acquired pneumonia you can use. Now these recommendations, I'll again come to the other uses of steroids in ICU. And definitely not to be used in sepsis patients without shock or major trauma, head injury, and influenza patients. So now I have discussed about using septic shock. I'll discuss a bit on the use of ARDS in steroid use in ARDS, CAP, meningitis, and I'll have and a bit just one liner on the cardiac arrest. So this I've already discussed. So use of steroids in patients with just a quick recapitulation of the side effects of steroids: hyperglycemia, hypernatremia, hypokalemia, elevated urea. Now, it can also cause metabolic alkalosis. It can promote stress ulcer. It can cause infections. It can cause muscle weakness. But at low dosages, there is no risk of increasing infection or stress ulcer, metabolic alkalosis, etc., or even myopathy. So, when you're using it at low dose, it definitely causes hyperglycemia at whatever dose you use. There is always a degree of hyperglycemia that can happen. There is always some hypernatremia, hypokalemia that can happen, and some isolated elevation of urea, not creatinine. But it will never cause infection per se. So hydrocot or methylpred at a low dose not associated with per se infection. It can be used unless there is some particular contraindication like influenza. What are the other uses? What is that we can use whenever there is severe bronchospasm and anaphylactic reaction? However, we have to remember the choice is adrenaline first. It is not steroids. Steroids takes time to take its onset. Prevent post-extubation stridor. CLT stand for cuff leak test. So if you have a cuff leak test which is negative, means there is a no cuff leak, you give a steroid, wait for 2 to 4 hours, and then directly extubate. You don't do a repeat cuff leak. ARDS net. So this is a question that is put forward, but the answer is no. You don't do a repeat cuff leak. If the cuff leak is negative, give a steroid, wait 4 hours, extubate. In ARDS, there are multiple trials with steroids, but we have to remember the base trial till date on ARDS or use of steroids is DEXA ARDS trial in 2020, which showed that a 20 mg DEXA for 5 days followed by 10 mg for 5 days, total 10 days duration associated with better ventilator free days, reduced mortality, and so and so. But we have to remember that ARDS is a very diffusive term. Nobody knows actually what ARDS is because under this curtain of ARDS, there are different entities which behave in a similar way. Severe pneumonia, obstructive pneumonitis, you can have a bronchiolitis obliterans, you can have an organizing pneumonias, you can have eosinophilic pneumonias, hypersensitivity pneumonias, acute eosinophilic pneumonias. So different entities can present similarly. So where do exactly steroids perform well are the ones where they have an increased inflammation, like hypereosinophilic syndrome or eosinophilic pneumonias, organizing pneumonias, or associated background of severe pneumonia itself or bacterial pneumonia or a obstructive airway disease like COPD and asthma. But there is no role in giving steroids in prevention or a delayed ARDS presentation, say more than 14 days. There is no use. Again, no use in prevention of ARDS. So only in treatment purpose, give early steroids. Any steroid can be given, be it methylprednisolone, dexamethasone. As I said previously, the anti-inflammatory ones are preferred here. Prefer methylpred or dexa over hydrocot here. However, if you're using hydrocot, it is also acceptable alternative. And coming to the dosages, 40 mg methylpred for OD for 5 days, that's a recent dose. It can be also used in pneumocystis pneumonia where your PO2 is severely less, that is less than 70, with a gradient, alveolar arterial gradient of more than 35. This is one-liner MCQ that can come, nothing more than that. Now, what is the role of use in meningitis? In acute bacterial meningitis due to strep pneumo, you can use it. It is advisable to use. Other agents of typical meningitis, not advisable to use in areas where HIV is prevalent, like our country, like India and Southeastern Asia and all. It is advisable not to use because it is associated with more risk of increased infections. No role in traumatic brain injury and spinal cord trauma. There was the role of steroids is still not mentioned in ACLS guidelines. However, one recent trial came that use of methylpred as a large dose of 500 mg during cardiac arrest leads to earlier or higher greater chance of ROSC achievement. However, it is still to come in the guidelines or there is no modification has been done as such. Now, there is one drug that we use during induction or intubating patients, that is Dromidate. It has been shown to reduce the 11 beta hydroxylase enzyme, which is a main important enzyme in the production of cortisol from cholesterol. And a single dose, either or an infusion, both associated with equal reduction in the steroid synthesis. and it can be lead to a worse outcomes in ICU. There are recent papers coming up that intermediate use is associated with worse outcome. Coming to now, the entire steroid deficiency is covered. Now there are small topics which I'll be covering in the next 15 to 20 minutes. So now, next part is Cushing syndrome. Cushing syndrome is when you have cortisol excess in your body. It's either it's from the pituitary, then it's called as Cushing's disease, or from the adrenal gland, in which case adrenal gland hyperplasia is the cause. Sometimes when you do a radionuclide scan, you would see that the adrenal glands are not the pituitary at the source, but an exoectopic acetate secretion from a lung tumor or a paraneoplastic cause is secreting the hormone. The clinical features range from a variety of symptoms like high blood pressures, hyperglycemia. There is a buffalo hump, that is there is a thickening of the neck. You have a central obesity with purple striae. That's the classical description of what you see. You can have a moon faces where you have enlarged facial fat with kind of superficial telangiectasia, that is reddish vessels which are seen, and the cheeks looks reddish. Along with that, you have brittle bones because of steroid increases the osteoporotic tendency. You have because of the high blood pressure, hyperglycemia, you can have cardiac hypertrophy. You can have adrenal tumor as a primary cause. Obviously, you can have the abdominal mentioned. You have amenorrhea in females. Mostly, it is prevalent in females. That is almost 5:1 ratio. And telangiectasia are seen. Easily bruising of the skin or fragile skin is also seen. So how it is relevant in our critical care? So we need to be careful about this. So we have to careful about, one is that the airway. So we can have a difficult airway when we're intubating these patients plus fragile skin. We can have difficulty in cannulation. The blood pressure cuff has to be of proper size, otherwise it will have false recordings. And during intubation, we have to take care of the obesity part. So RAM position and all those are important, and protein intake should be adequate. There are also high risk of infection, so anti-infective measures should be at par, and careful precaution for fall because this patient can have easily pathological fractures. Screening can be done by a 24-hour free cortisol assay. If that is elevated, then you can do a dexamethasone screening test. That's a dexamethasone suppression test where you go to give a low dose 1 mg at night and check in the morning. Normally, what happens if it's that your cortisol is getting synthesized from in an excessive manner, then a dexamethasone won't suppress it adequately. So a normal response is an adequate response with less than 500 of absolute value, 500 nanomoles per liters of absolute value of steroids. But if it's more than that, that indicates that there is a cortisol excess, and it has to be confirmed whether it's a pituitary cause or a gland cause by virtue of a high dose dexamethasone suppressor test. Not going to the details of how it is exactly done, not useful for particularly in ICU, but you can just remember the name. High dexamethasone test, that is for confirmatory diagnosis. For screening, it is a low dose dexamethasone suppression test. Roughly speaking, if your ACTH and cortisol both are elevated, it's a pituitary cause, or that is more specifically Cushing's disease. If it is ACTH is low but cortisol is elevated, it's a gland which is at fault. One important finding to remember, that the best or most sensitive way to diagnose this Cushing's is a inferior petrosal sinus thrombosis, inferior petrosal sinus sampling. So if you draw a petrosal sinus blood and the ratio of petrosal sinus blood is to a serum levels of more than 2, that is help to diagnose patients with Cushing syndrome much more specifically. So this is one important, one liner that you can remember. So different patterns of how it is the tests are interpreted. Again, as I said, that if you do a low dose dexamethasone suppression test, cortisol will be elevated in all of them. There will be a suboptimal reduction in the cortisol levels. After the high dose, if your ACTH is low and your cortisol is suppressed, that means the HP axis is working in a hierarchical manner. So that's the pituitary which is at fault. If the ACTH remains low but the cortisol is still elevated, it's the adrenal gland which is at par. Coming to the management, so you manage the blood pressure, sugars, careful positioning, all the supportive measures, and anti-steroid agents. Ketoconazole is usually given, or a metilapone can be added. Ketoconazole can be given in these cases. One thing I forgot to mention is that it is also associated with metabolic alkalosis, and hypernatremia, hypokalemia. So I think the metabolic component I missed out. I mentioned in additions, the reverse will be true here. Metabolic alkalosis, high blood pressure, high sugar or recent history of weight gain, diabetes, uncontrolled sugar, blood pressure, along with hypernatremia, hypokalemia should point towards a Cushing's etiology. Con syndrome, it is isolated adrenal gland hyperplasia involving the mineralocorticoids. So you got you don't have a hyper, what you say, uncontrolled sugar, but you get uncontrolled blood pressure, metabolic alkalosis. So Cushing's minus the diabetic and the osteoporotic component is Conn syndrome. And the diagnosis is done by something known as a salt loading test, where you give adequate salt to the patient. Adequate salt should reduce the renin levels, but if it is primarily elevated or other aldosterone level increases, then sorry, I was telling in the right manner that salt loading reduces renin level, and if renin is reduced, normally aldosterone is reduced. But if aldosterone is still elevated, aldosterone to renin ratio is also elevated. That indicates it's a primary aldosteronism. Management is done by mineralocorticoid receptor antagonists like eplerenone or spironolactone. You have to go blood pressure manage and you give adequate potassium replacement. Coming to the last portion of our topic, another important topic of discussion, that is the thyroid gland. So normally what you have is thyroid gland. It's normally it is situated again in the neck, around the trachea. The anatomy I'm not going to details. The hypothalamus secretes a thyroid releasing hormone which acts on the pituitary to secrete TSH. It also acts downstream on the thyroid gland to release T3 and T4. So these are the major two hormones. Among them, T4 amount wise is much more, and it is much more commonly present in our blood. T3 is the most potent form. So among the T4, the 90% of T4 gets converted to T3, and T3, 10% of T3 is directly derived from the gland itself. So T3 is the metabolically active form which acts by the intracellular receptor similar to our steroids. Half-life of T3 is shorter, 1.5 to 2 days. T4 has a longer half-life. The difference between T3 and T4, T3 has 3 iodine molecules or ions. So it is triiodothyronine. T4 is four iodine molecules. That's the only difference. Molecule iodine ions. Now the thyroid hormone is bound to, again similar to steroids, thyroid binding globulin, prealbumin, albumin. In critical illness, now that's now the interesting part starts. I'll come to the next slide. I'll be discussing it. There is enzyme known as deiodinase. This deactivates the thyroid hormones. There are different isomers of that, D1, D2, and D3. Just remember that D1 and D2 normally are present and they help in the metabolism of thyroid. So from T4, it will be converted to T3 and then T2 and T1. So it will get rid of its iodine moieties and then subsequently get broken down. And then ultimately it is metabolized by the liver and glucuronide conjugated and then released into the stool. Due to variable binding proteins in the critical ill patients, do not treat a thyroid function test which is abnormal without signs. This is one golden statement or take home point from our today's discussion. You see a random TSH value of say 15 and you decide to take action on it, give 100 mics of altroxin stat and action. So do not treat isolated TSH levels just without the background symptoms. So because as I said that in critical ill patients, there is a lot of change of the thyroid binding globulin albumin level. So the free fraction goes up. So even if your TSH is low or TSH is high, you probably think, okay, it's a gland cause, T3, T4 might be low, but the free fractions are always elevated. So it is always advisable to check your free fraction in these cases. So advise a TSH and free T3 and T4 if you want to be sure about your physiology. These are the different types of deiodinase enzyme that I showed. So there is a D1, D2 which is normal physiologically present, D3 which helps in formation of reverse T3. So this is one thing that happens in Diren's physiology, that is in ICU. That is that the type 3, the 5' deiodinase enzyme, it leads to conversion of T4 to a reverse T3, which is inactive form, and therefore the T3 level goes down, the reverse T3 goes up, and because T3 suppresses the TSH level, so no longer the TSH is TSH stimulation is there, TSH inhibition is there, so TSH levels are either normal or low. And that's why now there is an interesting term that I'll be discussing, that's the myxedema coma. It is now called as it is renamed, or rather should be renamed as dysfunctional hypothyroid syndrome in ICU, and this is known as a non NITS stands for sick euthyroid syndrome. Okay, so this is not this is what is the it is an equivalent to sick euthyroid syndrome, that the it is normal without obvious hypothyroid signs if you have an isolated elevation of TSH. So NITS or sick euthyroid should be treated only if there is an associated skeletal muscle dysfunction, But again, it's a kind of a controversial topic. What to be treated? There is no role of treating with thyroxine in in this scenario in CQ thyroid syndrome. Physiologically speaking, TRH can be given, but it is not easily available. You can There is some role of antioxidants again, but there is not much of a huge benefit. One important drug that denains the thyroid function is amiodarone. Amiodarone, first of all, it goes whenever you're using for any other purpose, it can simply lead to a sick euthyroid kind of state, usually seen after a week or so. So that simulates the sick euthyroid. That's a usual thing. Sometimes it causes amiodarone-induced thyrotoxicosis, where you have an autoimmune kind of phenomena where the amiodarone iodine molecules goes and binds to the thyroid gland, and that leads to increased hormonal release, and that leads to thyroid storm or thyrotoxicosis. And rarely it also causes hypothyroidism because it inhibits the thyroid hormone synthesis. So amiodarone can cause both hypo, hyper, and euthyroid syndrome, like the sick euthyroid syndrome. Thyroid storm, in one important discussion. So thyroid storm is whenever you have a hyperthyroid features with clinically significant toxic features like severely increased heart rate, severely increased blood pressure, and increased in the perspiration, increase in basal metabolic rate, temperature, GIT symptoms. So the diagnosis of thyroid storm is always clinical. It is not based on lab. The diagnosis of hyperthyroidism is based on lab values. That is more T3, T4 is elevated, TSH is down, and so on. But if you got toxic features, so that indicates it's a thyroid storm. So hyperthyroidism is not a life-threatening emergency. But if you had this phenomena, the cardiac involvement in terms of atrial fibrillation, high output cardiac failure, or you got delirium, hyperexcited states, or you got diarrhea, liver failure, it indicates that there are toxic features. What are the signs of hyperthyroidism as a cold disease? I mean, without the toxic features, classically that is the you've seen in Graves' disease, that you see all these lead lag sign, the Mobius sign, the stale wag, the Geoffroy's, delirium pace, and you can have ophthalmoplegia. There is no need to go in depth. You can read up on yourself. This is more prevalent in thyroid per se, gland discussion, anatomical discussion. In ICU patients, mostly these patients will have some essential tremors, tachycardia, hypertension, and pulmonary erythema. So that's the diagnostic point. High blood pressure, sugars, hyperdynamic circulation, bound. You can have water hammer pulse. So your pulse is kind of it's pulsating, it's moving, coming and meeting your fingers and immediately running away, that kind of a phenomena. And you can have high systolic blood pressure and a low diastolic blood pressure. You can have pulmonary erythema, so that's a non-liver cause of pulmonary erythema. So your palms and soles are kind of warm and it's pink and it's erythematous. You can have liver failure. In rare cases, you can have liver failure because of thyroid storm itself. Whenever you're managing a thyroid storm patient, other than your supportive measures and antithyroid drugs, always look for the airway, because you can have a gland sitting on your neck. If the patient is an emergency, you want to intubate, you always take adequate precautions. You can have a DIC secondary to thyroid storm. Now, how will you diagnose it? So, there is a criteria that is known as the Birch and Birch scoring system. The name is not mentioned. It is Birch and Birch, BURCH, Birch and Birch. So there is a different point categories based on temperature, cardiovascular system, atrial fibrillation, heart failure, GI symptoms. The scoring is done from 0 to 44. So if it is 0 to more than 45, it is more than 45, definite thyroid storm. 25 to 45, intermediate risk, and less than 25 rules out thyroid storm. So one important parameter among them is resting tachycardia. If your patient is having a resting tachycardia or unable to sleep, that is also an important issue. It points towards a possibility of thyroid storm. Now, how will you manage this? I'll go a bit on details. So first of all, the first drug to be given in blanket without thinking what is causing it is that it's not an antithyroid drug. Why? Supposedly you have something known as an autoimmune thyroiditis or a riddle thyroiditis, or you got amiodarone induced thyroiditis type 1, where initially the thyroid gland is inflamed and releases a lot of hormone. If you give an antithyroid medication, then the thyroid hormone suppression occurs immediately. Your patient gets improved. Afterwards, there is no thyroid in the body itself, and there is a prolonged period of hypothyroidism. So, in an acute stage, whenever you are not sure of the etiology, you can give it in Graves' disease. You have to give it Graves. But if the etiology is other than Graves, it is always preferable to avoid antithyroid drugs. So first drug is a steroid. So steroid hydrocortisone 300 mg stat followed by 100 mg TDS. It blocks the peripheral T4 to T3 conversion and reduces the immediate toxic effects because of T3. But the T4 is still prevalent in your body. Now if you are suspecting grapes, you give a methimazole. Now you have there are two things to remember. Methimazole and Lugol iodine solution are used one after another. So methimazole or propylthyroxine reduces the synthesis of hormone, synthesis of steroid hormone. The dosages are 20 to 40 for methimazole and 1 gram bolus followed by 200 4 or Q4 hourly for propylthyroxine. Methimazole is contraindicated in liver disease. Propylthyroxine can be given in liver disease, but it is avoided in liver disease. Methimazole is preferred in liver disease. Propylthyroxine is avoided in pregnancy. When you give Lugol iodine solution, what it does, it by the Wolff-Chaikoff effect, it reduces the further thyroxine synthesis or secretion. So it kind of constipates the thyroid gland. However, if you give it without an antithyroid drug, it might cause the reverse. It might actually increase the thyroid hormone synthesis by a phenomenon known as Jod-Besto effect. So, whenever you are using an iodine along with the methimazole, give a methimazole dose stat first, followed by iodine, not the reverse. Then, but again, as I said, the methimazole and the iodine are handy only if it is a gland cause or the Graves' disease. If it is other than Graves, autoimmune causes and all, you need not give those. You need not give round the clock. Cholestyramine 4 gram QID can be given. Thyroid hormone, as I said, it is metabolized in the liver, bound to glucuronides, excreted through the enterohepatic circulation. Again, 90% above is again circulated back, absorbed back. If you block the enterohepatic circulation, you are reducing a lot of thyroid hormone in the body. And it can be given even if it is not a thyroxine tablet overdose. So even if you are having a body which is secreting excessive thyroxine, you can give cholestyramine. Obviously, if you are having an ingest thyrotoxicosis factitia, that means you have excessive amounts of thyroxine intake that leads to thyroid storm, you can use it cholestyramine. And whenever you using a beta blocker, it is preferable to use a non-selective beta blocker, so that has an action on both the beta or across all the beta and some alpha blocking effect if it is preferable. But it's preferably beta 1, beta 2, everything has to be blocked. So a propranolol is a preferred agent. Other than that, you have to go for cold sponging for temperature management, paracetamol, treat the arrhythmias, give adequate analgesia and sedation. Now, coming to beta blockers, the beta blockers are not a child's play. When you're using a beta blocker in this course, there are pros and cons. Pros are what? It obviously helps your early management, early resolution of symptoms. Used in amyloid endocytotoxicosis, and it does not deplete the thyroid T4. So that's an advantage. However, the cons is if you are having a tachycardia-induced cardiomyopathy, if you are using in a high output cardiac failure, so the heart is already at stress, probably beating higher than normal, 160, 170 rate. The cardiac output is not adequate. If you get a beta blocker, you think that you're reducing the heart rate, actually can be detrimental, and it can precipitate cardiogenic shock. So in a patient with thyroid storm, always monitor your cardiac function by echo, enzymes like proNT-proBNP. When there is not acute heart failure or imminent heart failure, you can use beta blocker. In refractory cases, it can be plasmapheresis can be used. PLEX stands for plasma exchange therapy. That is, there is a recommendation by the extreme guidelines when to use, when not to use plasmapheresis. It can be used. And the last is when the gland is at fault, you can go for a thyroidectomy. Or whenever you are not finding a cause, but probably the pituitary is also the cause, but you can remove the gland because that's the final common pathway of synthesis of thyroid hormone. There is one Japanese criteria for diagnosing the severity. Just for the namesake, I have added this. Now coming to the reverse of thyroid storm, that's a myxedema coma. So again, as I say, myxedema coma is a clinical diagnosis. It's not a lab diagnosis. Thyroid storm, again a clinical diagnosis. Hypothyroidism is a lab diagnosis, lab plus clinical. But myxedema coma is a purely clinical diagnosis. When you have a patient coming with a background of hypothyroidism, patient who was taking hypothyroid or known hypothyroid for many years, took drugs but let go of the drugs for some illness of some sort. There is history of probably history of weight gain, probably anasarca, thick skin, obesity, deranged liver function, and deranged lipid profile, hypertriglyceridemia. All this indicate a prevalence of hypothyroidism. Other than that, for female, probably menorrhagia or menometrorrhagia, change in the period cycle, Again, weight gain, obesity, higher diastolic blood pressures. These are and cold intolerance. These are the telltale signs of hypothyroidism. When the with this background, there is sudden worsening of hemodynamics, sudden hypotension, hypoglycemia, raised PCO2. These are signs that the patient is having a dysfunctional thyroid gland. And this entire time that the myxedema means swollen up, and coma means coma. Both these terms are wrong. Both terms are misnomer. Not all patients of myxedema will come to you with swollen body and anasarca, having a history of hypothyroidism. Even if they come, not all of them are having a comatose status. They might be having a hypothyroid state or significant hypothyroid state, but not coma. And whereas you can have a lean thin patients who let go of their medicine and within 2 to 3 days they are not going to swell up like anything, but they will come in comatose state. So don't go by their looks, and it does not always cause coma. Patient can be drowsy, non-comatose. They can have a very refractory shock. So it is much more about the hemodynamics as well as the overall clinical presentation and an overall background which suggests an hypothyroidism, not always an anasarca. Now coming to the exam findings, this we already know that you can have edemas, you can have thick skin, you can have rough hands. There is the lack of kind of sweating that is used to say dry skin, altered elephtys. That is a finding of hypothyroidism, and refractory hypothermia, hypoglycemia, hypothermia, bradycardia in a shock patient indicates myxedema coma. Treatment is give a levothyroxine. Better is to give levothyroxine and not T3. Now this is one interesting concept. T3 is much more potent, we know. But for an acute stage, we avoid T3 because it also has a significant potential for causing atrial arrhythmias. And for avoiding atrial arrhythmias, it is better to give a high dose of T4 rather than giving a T3. So give a 200 to 400 micrograms intravenous. If you thyroxine, intravenous is the choice. And then 1.5 per kg per day, either IV or a tablet form or a ice tube you can use in a comatose patient. If you don't have an option, you have to go ahead with a tablet form. And if you are suspecting these patients will come with lot of confounding. Patient is hypoglycemic, patient is in shock. You should also think about steroid, hypoadrenalism, that is cortisol deficiency. You should give steroids. For hypoglycemia, you should give dextrose, adequate fluid resuscitation. And these patients can have shock with metabolic derangements. You should give thiamine as well because that's one of the coenzymes in your pyruvate decarboxylase pathways. So it's generally a cocktail of thiamine, dextrose, thyroxine, and steroids. These are usually given. There is a proposed sequelae as to how to give, but generally that's not followed. It does not have to be followed as long as you are giving all of them. Now, these are the questions. So, do I have time for questions? So, do I have time for questions? I mean, if I have 5 minutes, then I'll discuss 5 questions. Okay.
Yes, sir, you have time. You can.
Okay, so I'll take 5 minutes of your time, and in 1 minute we have to answer these questions, and then we'll discuss. So, which of the following after this all this discussion? Which of the following is true about CERSI? So, in patients with sepsis with normal mean arterial pressure, CERSI can be a cause. Normal values of 9 to 24 is holds true in critical ill patients. Value of more than 20 at the baseline rules out CERSI. ACTH stimulation test should be done with low dose, and change after ACTH less than 9 predicts worse outcome. Can we have quick answers? We'll discuss and then we'll wait for 20-30 seconds and then we'll. The answer is which of the following is true? You can have multiple. I mean, you have to apply true or false against each of the options. Sorry, I mean, it's probably my mistake, the way I formed the question. It's which of the following is true? Okay, let's see some answers. Let's see some answers. Okay, so I'll discuss the individual points. Okay, there are a lot of answers, so I'll discuss them. First of all, in patients with sepsis with normal MAP, you should not think about CERSI. Okay, so that's that's false. Normal value of 9 to 24, although we don't have an option, we always look at the normal value for the labs. But in critical ill patients, it does not always hold true. And that is why, patients with baseline more than 34 had worse outcomes. So this is again false. So option 1 and 2 both are false. Value more than 20, this is liter is a wrong thing. This should be deciliter. But again, this is again false because you can have normal or higher normal baseline value, but still the ACTH stimulation can be negative, which point towards CERSI. 4 is ACTH stimulation should be done with low dose. Again, false, because you're the recommended to use a high dose, and change after ACTH less than 9 predicts worse outcome. This is true. So you have this, someone mentioned option number 5. Yes, that is true. So a change of ACT after change ACTH stimulation, if the delta cortisol is less than 9 at 60 minutes, that predicts a worse outcome. Um, just a quick take on this. Sometimes we don't always go for the ACTH stimulation. If your cortisol levels are kind of lower normal, patient is having shock, you think that there is a possibility, you just simply give steroids. That's a practical quick tip. Which of the following is true about myxedema coma? Generally, all of the patients are obese, thick-skinned, and comatose. Combination of thiamine, dextrose, hydrocort, thyroxine is useful for metabolic shock. HAT therapy. HAT stands for hydrocortisone, ascorbic acid, that is vitamin C, and T stands for thiamine, has been shown to provide mortality benefit always. Treatment should be started if suspicion is present, as it's associated with high mortality. T3 is more potent but toxic than T4. So someone wrote 2. Yes, that's right. Number 2 is correct. Combination of thiamine, dextrose, hydrocortisone, thyroxine is used. Metabolic shock means this kind of scenarios when you are uncertain about etiology, you can use these agents. Probably that sequelae is there, but I don't want to focus on the sequelae. But you have to use. Option 3, just remember, HAT therapy was sensationalized by one of the greatest ever intensivist of ever born. But this trial has been heavily criticized because it was many data were forced, and this was manipulated. And later on, large trials have shown that this cocktail of the HAT therapy has not shown any significant benefit. So it is outdated, not used nowadays. Treatment should be started. You can use thiamine when it is indicated. You have to use steroids when indicated. You have to use thyroxine when indicated. Vitamin C as such, no role. So HAT therapy is no role. Option 4, treatment should be started if suspicion is present, as it is associated with high mortality. Yes, absolutely. You don't wait for the lab values, because if you don't give, patient will die of shock. So you have to start if you have a clinical suspicion. And T3 is more potent but toxic. Yes, it is true. So T3 is more potent, definitely, but it is more toxic. It can cause atrial arrhythmias. Option. Come on to question number 3. Which of the following again is true about thyroid storm? Diagnosis always based on lab values. Steroid is used for treatment. Beta blocker can be used as a solo therapy. PTU, that is propyl thyroxine, should be given after Lugol solution, and Plex can be used. So which of the following are true? There are 2 options which are true here. Can we have some answers quickly? So 2, yes, 2 is true. Steroid is used for treatment. Good. And obviously 5, 2 and 5. Good. Many of people have done it correctly. So diagnosis is not based on lab values. When you call it thyroid storm, it's a clinical plus baseline hypothyroidism. Steroid is used for treatment is true. Beta blocker not for use for solo therapy, as I've already discussed the pros and cons. In heart failure patients, it can precipitate severe shock, so it has to be guarded. Propyl thyroxine should be given prior to leucocytin. So I say again, it is false. Propyl thyroxine before, leucocytin after. Plex can be used, again is true. Coming to question number 4. Which of the following is true about steroid use in pneumonia as per the latest literature? Now, this I have discussed a bit. Could not go in depth because again it's a huge topic on its own. But here I'll discuss a bit. So, which of the following is true? Steroid is indicated in severe pneumonia without shock. Methylprednisolone is preferred over other agents. Dose is 400 to 500 mg per day of hydrocortisone. Higher dose of steroids lead to better outcome. Cannot be used in immunocompromised patients. So, which of the following is true? Yes, some Estereja, you will. Yes, got it bang on right. So it's actually 1 and 5 is true. So the latest trial on steroids at the Cape Cod trial, which was published in 2022 NEJM or 2023, which showed that use of steroid hydrocortisone 200 mg per day in patients with severe pneumonia without shock led to mortality benefit, reduced ventilator free days, and therefore steroids is a standard of care as per the latest guidelines. The guidelines have not been updated. That's why I use the term as per the latest literature. So you might jot down the trial, Cape Cod. You might want to go through the abstract. So it's Cape Cod trial. I think the author's name is some Jiung or Leung. It's from France, which showed that it can be used in severe pneumonia without shock. Although the IDSA 2017 guidelines on pneumonia does not recommend giving steroids. So that's an update that we have to update ourselves based on the exam patterns. Methylpred is not is preferred over other agents is partly true but not wholly true. You can use dexamethasone, methylprednisolone in patient is in shock. You can use hydrocod. So it is not a true statement per se. The dose is much lower, less than 400 mg per day. So 400 to 500 is a higher dose. So the option 3 is false. High dose leads to better outcome. Definitely not. The dose is always low dose, septic dose or a pneumonia dose is less. So option is 4 and cannot be used in immunocompromised patient is again, sorry, this one is false. Option number 5 cannot be used in immunocompromised patient is actually false. It can be used in immunocompromised. Okay, so someone wrote 1 and 5, so only one option is true. So it can be used in immunocompromised. If your immunocompromised comes with severe pneumonia, you can use it. It is not that steroid is always harmful in immunocompromised patients. There is a particular set of patients who are immunocompromised where steroid cannot be given. But as a blanket statement, it's false. So only one option is true. That is question number 1. Last, which of the following true about steroid is in septic shock? Previous was on pneumonia. This is on septic shock. Now, this, if you remember the trials which I have discussed, you could answer, or just this is the last question. Adrenal trial showed mortality benefit, approx showed harm, should be started only if noradrenaline dose exceeds 15 mics per hour. As per literature, high fludrocod should always be used with hydrocod. Hydrocod infusion is preferred over boluses. So, which of the following is true? Let's see who answers it correctly. So the answer till now nobody has got it correct actually. Yes, I think Esraja was close to that. None. I mean that is also an acceptable answer, but option number 4 is correct actually. As per the literature, that's why I have used them. As per the literature, fludrocortisone should always be used. Again, somebody sitting, instead of me, some other person can refute this statement. But as per the literature, strictly going by the literature, the trials which have combined fludrocort with hydrocort have consistently been shown to have better outcomes. But could be a trial design error, could be something else. And as I said, physiologically does not make sense. But if you ask me, hardcore as per the literature, fludrocort should be used along with hydrocort. The rest all are false. Adrenal was a negative trial, approx was a positive trial, and current sepsis recommendation is to start whenever your ongoing vasopressor use. That's the term, ongoing vasopressor use. No longer particular dose of steroids, noradrenaline where you have to use. If you have a patient with sepsis, fluids you have given an ongoing vasopressor use, you should start steroids. And last one is that only infusion is not preferred. So this I have already discussed. Either you give boluses or you give a bolus followed by infusion, not only infusion. So that concludes the day. Any questions that I have not come across any questions? Any questions?
Aspirants, if
Okay.
you have any question, you may ask now. Asta, I guess there is no question for now.
Okay.
If any question arises, we'll set up a meeting with you.
Sure, sure. And
And
just
so,
to conclude I mean, whatever I was about to speak before you conclude the entire session, is that this entire set of questions I've devised from my based on the current literature. And to be very frank, other than few things, there is not, there is no black and white about many options that we find here. So, just like question number 5, that the answer number 4, someone pointed out that all of them are false actually, is also in a way true. But, some things are there which we read up based on the updates and the recent trials. And sometimes it comes in the exams. So I want you to focus on that. Do not worry too much about, what exact updates you cannot go all the through all the updates, but when you come across them, just jot down, write it down in your paper or in your book, whichever you're reading, so that if it comes, you have a bonus point ahead of others. Thank you.
thank you very much, sir. And aspirants, as you know, we are going to have a EDIC crash course that is 15, 16, 17th of March. For registration, you may contact me. Thank you.